Good evening. Welcome to another edition of OrthoCarolina's webinar series. My name is Michael Bates. I'm a board-certified orthopedic surgeon. I take care of patients that have hip and knee arthritis, and I specialize in performing such surgeries like hip or knee replacement. Tonight, we're going to be talking about early discharge after total joint replacement, whether that be the hip or the knee. A quick note, this event is being live streamed on our social media platforms, including YouTube, LinkedIn, as well as Facebook. So please do not hesitate to ask any questions that may come up during the presentation. I will try to address all of them at the end of the presentation. A little bit about myself. This is my 10th year of practice. I did my medical school at the University of Virginia, which is where I'm from. I did residency here in Charlotte, North Carolina, followed by a fellowship at the Hospital for Special Surgery in New York, where I performed studies in joint replacement. Since being back here, I practice in the University City region of Charlotte. When I'm not here, I'm usually at home with my 3 little boys and my wife, hanging out with them. So one way or another, I'm always keeping pretty busy. But without further ado, I would like to dive into tonight's topic, discussing early discharge after total joint replacement. So just by way of introduction, I think we're all aware that the demand for hip and knee replacements has been increasing over the years. In fact, just in the United States, this procedure is performed about 1.2 million times per year. About 2/3 of those are knee replacement and 1/3 is hip replacement. But because of those numbers, you probably either know someone in your home or a friend who has had or is thinking about such a procedure. There's been a pretty marked shift towards outpatient surgery over the years. Now, not long ago, patients may stay in the hospital for a week, 5 days, or something like that routinely after a joint replacement. But even well before COVID, that was changing fairly rapidly because we found that folks were actually doing better at home. Patients were happier being at home versus having to be in a hospital type facility. But with COVID, that really only accelerated the transition to outpatient surgery, and it's been a big change in our specialty. I would really go on to say that it is becoming the standard in select patients, and we'll talk a little bit more about that in the remainder of the presentation. Well, the first question is why? Why even consider same-day discharge? There's lots of reasons, but I'll highlight a few here. Number one, reduced infection risk. Multiple studies have shown this. Some studies have shown that it's comparable to inpatient stays, but there have been others that do show decreased infection risk. I think that's intuitive. If we can get you into your home environment, instead of being so close to folks who may be in a facility due to some type of serious illness, chances are your infection rate would be a little bit lower. Higher patient satisfaction is a no-brainer for me because most folks are going to be happier in their own home, their own lazy boy recliner chair, than having to be in any type of facility after you have a surgical procedure. You're just more comfortable being in your own setting. The great thing about it is we have either comparable or in many cases better outcomes being shown in the data when we compare the two groups. Additionally, and this is important, the costs are much lower for patients. And this is, immediate savings that people can see, and it affects your pocketbook. So this is a real consideration. So the first thing I think we have to say, though, is that outpatient surgery, while it is very common and it's very successful, it's not for everyone. And one of the most important things that we as surgeons have to do is make sure that we're offering this to the correct individuals. Now, as you see on the slide, I say that you have to be a healthy, motivated person, but I want to make sure I put a little asterisk beside the word healthy. That doesn't mean that you can't have medical problems. It just means that they have to be controlled. It's okay to be diabetic, but we want you to have controlled diabetes. It's okay to have hypertension, but we want it to be properly controlled. Being motivated, I think, is quite important because when you come into these surgical procedures, you really do have to be prepared to do the rehabilitation that comes afterwards. That's physical therapy and so forth. So being self-motivated is critical, and having a good support system at home. I always tell patients in the office, this is going to affect you more than anyone as the patient, but number two in line is your family, because they will be the ones who will be there with you, watching you go through the recovery, helping you with exercises. So it really does become a family affair. So there are lots of things that go into early discharge. It's not as simple as saying your surgery was a success, your pain is controlled, and we can let you go home safely. Really, the process starts well before the day of surgery. A huge component of that is patient education. We do this in many ways. First of all, we give you booklets so that you can go home and read about the surgery. You can read about the day of surgery, even information that tells you about the facility, so that you'll have a sense of familiarity prior to the day of surgery. This really can decrease anxiety, and you come into the whole process feeling much more confident. Preoperative physical therapy is another critical aspect. When you go to a preoperative physical therapy class, you're going to start learning all of the techniques and how to use the equipment that you're going to have after your surgery, but doing it prior to surgery lets you do it in a way where you don't have as much stress, you don't have as much anxiety. It gives you a chance to go home and practice some before the day of surgery. Again, so when you come in for the day of surgery, you're going to have a lot more confidence and hopefully a lot less anxiety. And then lastly, it's really the job of myself, the surgeon, to provide you with realistic expectations so that you know what to expect. You have a lot of things that you have to juggle, whether that's family or your professional life. So having a good idea of when can you return to those things realistically? When can you get back to the roles that you're used to playing in your family are things that we try to go over ahead of time so that you can plan your life accordingly. Now, once we get to the day of surgery, here are some of the specifics. Everyone kind of asks, well, how do you control pain and what do you do for anesthesia? Well, there's lots of different things that we do. Number one, we do have a bit of an emphasis using what we call regional blocks. That's where we have an anesthesiologist that can perform small procedures that can really help to control pain dramatically during and after the surgical procedure. And by doing this, we don't have to use as many opiate pain medications. We know opiates are very effective at controlling pain. However, they have side effects, they can cause constipation. So we try to avoid those as much as we can. This is one of the main ways we do so. Local infiltration analgesia is critical. It's what it sounds like. This is during the surgical procedure. The surgeon actually injects local anesthetic, sometimes mixed with other pain medications, directly into the tissues around the area where we're doing the surgery. That has been shown to have a massive impact on postoperative pain, further decreasing the need for opiate pain medication. Additionally, there's cryotherapy, which is a fancy word to say cold application. We use machines that circulate ice cold water. That helps with the inflammation after the surgery. We also use non-opiate medications such as acetaminophen, more commonly known as Tylenol. We use anti-inflammatory medications, even starting before you go back for surgery. When you're in the preoperative area, we use those medications because it has been shown to decrease pain after the surgery. And of course, everyone is using only oral pain medications prior to being able to leave the facility. Early mobilization and physical therapy is another critical aspect. So if we look back 10 to 15 years ago, this is probably the opposite of what we did, where folks would have a hip replacement or a knee replacement, and we would kind of let them start resting for a day or two, then we would get them up out of bed. We came to realize that that's really not helping the individual, and in some ways could probably be detrimental to recovery. Early mobilization, walking within a few hours of surgery, can actually decrease your pain, decrease your chance of blood clots, which is already a very low risk, but this further decreases it. We want you to be working on ability to navigate stairs before you leave the facility. Most of my patients, most of my patients have stairs in their home. So it's really important that people can get upstairs to their bedroom safely and know how to do so before they leave the facility. The home exercise program was discussed with patients prior to surgery, but of course we reinforce that and go over it prior to discharge as well. So the biggest thing to remember with these surgeries, the recovery starts on day 0, the day of surgery. There are certain criteria that you do have to meet before we say that you are appropriate for discharge. You have to be able to walk around safely using your walker. Again, you've been practicing that prior to coming in for surgery, so this is rarely an issue. Your pain has to be controlled with just oral medications. That's pretty intuitive because once you're at home, that's really what you're going to have with the oral medications. You have to be able to urinate, and you have to be able to keep water down. You don't have to have a great appetite, but we definitely don't want you going home getting dehydrated. So you have to be able to keep clear fluids down and so forth. We'll spend a good bit of time talking to your family or friends, whoever's going to be helping you after surgery, because we want them to be educated on what to expect as well. After surgery, it's really important that we have a method of communication with our patients, and there are multiple ways to do that. Number one, we use outpatient physical therapy, typically around 2 visits per week. Now, the physical therapists, they are our eyes and our ears. They are looking at your leg. They're looking at your hip. They're looking for swelling. They're looking for anything that causes concern. And we have multiple methods of communicating with the physical therapy team if any concern should arise. We use telephone check-ins. The power of the telephone is pretty amazing, just touching base with folks, understanding how their recovery process is going. So we usually will touch base with all of our patients within that first or second day after the surgery. We have 24-hour phone lines for any urgent issues that were to arise. Fortunately, that's a very uncommon thing, but that is something that we keep in place. And then red flag symptoms, things that you really have to be looking out for. Fortunately, there are very few of them, but we do go over those things so folks are not sitting at home guessing. So what are the outcomes, or what does the evidence show? Well, the studies show that you have lower complications in many of the studies, and some of the studies show that they're the same. But we have found that even with folks recovering in the comfort of their own home, you can do as well, if not better, than folks who are kept in a facility. Many studies have shown a lower readmission rate in optimized patients. Optimization refers to trying to get the things that we can control well controlled prior to surgery, such as if you have diabetes, we're going to talk to you about making sure we get that A1C level down to an appropriate level. But doing those things ahead of time, of course, will reduce the risk of complications afterwards. And again, we can show with the data that folks do have a faster return to their daily activities. So here's a generic timeline. A typical person undergoing a joint replacement surgery, they would come in fairly early in the morning. They would have their surgery, which usually takes about an hour to an hour and a half. Typically, we're going to use some type of regional anesthetic. By late morning, the individual should be up walking around, having the physical therapy team walk with them. And we're going over all those things, those metrics that we want to see a person meeting prior to discharge. And typically by early afternoon, the individual is able to be discharged safely home. So in summary, same-day discharge is safe and effective. However, careful patient selection is paramount. It requires a team approach. Your surgeon is important. Your anesthesiologist is important. Your physical therapist, the nursing team. There are lots of folks who are working right beside you, but as well as behind the scenes to make this a successful venture for you. And I do believe that this is not only the current state of joint replacement surgery, but it largely represents the future of joint replacement care. These are just some of the references used to put this talk together. And at this point, I'd love to entertain any questions that anyone may have. How does orthopedic research impact your practice? That's a great question. Well, orthopedic research is really how we stay abreast of the changes in our specialty. Orthopedic research is a lot of what I just presented in this presentation, where we can see that, hey, getting folks up, moving quicker after surgery leads to improved outcomes. So most of us will change our practice to accommodate anything that will help individuals recover better, more smoothly, and in less pain. Orthopedic research is a bit of a generic term, but that can encompass anything from early recovery after surgery to techniques that we use during surgery, pain control regimens. So it's a critical part of our practice evolving over time. What makes a patient a good candidate for same-day discharge after hip or knee replacement? Yeah, so that's I think it's a great question, because it's one of the things we spend the most time looking at. I think having some internal motivation is critical. Having a strong family support, absolutely critical. You got to have someone there that is going to keep you motivated if you have a day where you don't feel internally motivated. And just basic helping around. It's important to note that when a person goes home after these surgeries, you are not helpless. You can do a lot of things for yourself, and not only that, we expect you and encourage you to do a lot of things for yourself. But it's always good to have someone there to give you a hand, to help you if you're not feeling great that hour. And that's why having a reliable support system is really critical. We touched a little bit on having controlled medical problems, and I would still say that's a very important thing as well. What safety checks happen before being cleared to leave the surgery center? Yeah, so there was a few of those that we covered previously. We want to make sure that you can urinate, no problem. We want to make sure that you can drink water and you can keep that water down. You're not nauseated, you're not vomiting. We want to make sure that you can eat food and you're not nauseated and vomiting. Importantly, we want to see you walk with your walker. We want you to show us that you can do it safely, that you can balance yourself safely. We want to see that your pain is well controlled. Those are really the main things that we're going to be checking for. That's done with the nursing team, anesthesiologist, the surgeon, as well as physical therapist. So we have someone who's experiencing nerve damage after posterior hip replacement a year ago. What more can you be doing? Well, it really depends on the specific type of nerve damage. You know, the nerve, when you're talking about posterior hip replacement, we worry about that sciatic nerve, and I'm not sure if that's the one that you've been dealing with, but a lot of that is therapy-based. Sometimes we do specialized nerve testing to evaluate the integrity of the nerve. Fortunately, that is an incredibly uncommon thing to experience after a posterior hip replacement. Personally, I perform anterior hip replacement, but there are always risk of nerve injuries, just the risk is to different nerves. But in the rare occurrence, it's mostly supportive care, sometimes with some specialized nerve testing. Okay, we have an individual states they developed arthrofibrosis after having a knee replacement, which led to pain and limited range of motion. Should I be concerned about scar tissue developing? So arthrofibrosis refers to a condition where there has been scar tissue that has already developed. And in some individuals, the scar tissue formation is much more aggressive than in others. And if a person develops an excess amount of scar tissue in one of their joints, it can limit the person's motion. So generally speaking, if a person has been diagnosed with arthrofibrosis, then the scar tissue has already developed. So in a way, I don't think you have to be worried about it happening, but recognize that it has already happened if you already have the diagnosis of arthrofibrosis. When we see that happening, typically we're going to increase physical therapy. There are other things that we can do early on in the process as well. If someone is overall healthy, motivated, and has minimal controlled health issues, is it possible to have both knees replaced at the same time when undergoing robotic knee replacement? Yes, it is. Absolutely. That is a fairly common scenario. Now, I think that the individual has to consider the fact that having bilateral knee replacement done simultaneously, there are some trade-offs. You probably cannot do that on an outpatient basis. If you just had both knees replaced, typically that's going to require at least a short hospital stay. There may be some slight increased risk just because you're going to be under anesthesia for twice the time. And even though we keep blood loss to a very small amount, there will be more blood loss. So there are some additional risks associated with simultaneous bilateral knee replacement, but it is something that can definitely be done, and it is done. How does age affect surgery outcomes? I love this question. I have lots of patients who will commonly ask, "Am I still a candidate for surgery?" Their concern is that they're too old for surgery. And I always kind of give the same response. I am much more concerned about an individual's health than I am about an individual's age. In other words, it may be safer and more successful to perform a surgery on a healthy 85-year-old than a 65-year-old who, smokes cigarettes and doesn't take care of their health. So age is a factor, but it's one that is probably not nearly as big of a factor as most patients think. So it's a common part of my practice to take care of patients well into their 80s, and largely they do exceptionally well. How do you keep scar tissue from forming? Well, most of this comes down to that early mobilization. That's why we get you up moving around within 90 minutes of finishing your surgery, because if you're moving around, it makes it a little bit harder for that scar tissue to form. The physical therapy that you're going to start doing within days of surgery is another critical portion as well. Keep in mind that some of us are biologically predetermined to have a little bit more scar tissue formation. Some folks know that, some folks don't know that. But early on in your postoperative process, we are going to be checking you more frequently, because we are going to be looking for any of those things that give us a clue that, hey, we might have more scar tissue forming here, so that we can take corrective action early. But the biggest thing that the patient can do is work really hard on physical therapy, work on the exercises that they have learned early in the process. Where is the surgery performed on the hip for a replacement specially? Well, it depends on the surgeon. There are multiple ways to do hip replacement surgery. And here's the good news. They all work exceptionally well. If the surgeon is good at the approach that they use, then we really see outstanding results. Personally, I perform what is called direct anterior hip replacement surgery, where the incision is placed on the front of the individual's thigh. Other surgeons do it. Some surgeons do it the same way. Other surgeons do it in a different way. But that's called anterior approach. And in my hands, that has been my preferred way to perform the surgical procedure. Is there pre-therapy I can do before replacement? You betcha there is. Not only can you do it, but it's actually a requirement to do the surgery. Again, the goal here is we want you to come into the facility on the day of surgery, not nervous or second guessing, are you going to be able to do this? We want you to come into the surgery facility confident, having already practiced these things, and excited about being able to get started with your recovery process. And for that reason, we actually require that you do a physical therapy evaluation prior to the surgical procedure. So absolutely. Is using a cane an option opposed to a walker at first? No. Not really. And here's the thing. There are certainly individuals who could safely use a cane after the surgery, but a walker is just, it's more stable, it's more safe. For the first 2 days, I think you're always better off just using the walker. If you were to stumble, you have two hands with 4 points of contact on the floor. It's always going to be safer. And I just don't think you do yourself you don't do yourself any favors by rushing to get to the cane. Um, 6 months from now, no one's going to be thinking about the fact they used their cane for the first 2 days instead of a walker. And for that reason, since there's really no significant benefit to doing it, I think you err on the side of safety. You use the walker initially, and then you transition to the cane when it's a natural transition. And you'll know when that is because you'll start to forget the walker in the kitchen and you'll find yourself in your living room. That's when folks should transition to the cane. How important is it to have a caregiver at home after a joint replacement such as a hip? Well, it's a requirement, actually. It is important. And I'll be the first to admit, a lot of folks will go home and they will do exceptionally well. They'll fly through the recovery, and that is awesome. But there are just, small things throughout the day where it is really important to have someone who can just keep an eye on you, a person who can help you with a task you may be having a little bit more trouble with than you expected. So not only is it important, it is something that we do require that. Do ambulatory surgery centers have a lower rate of infection for hip replacement as opposed to an ER? I think that question is probably meant as opposed to inpatient facilities. And in some cases, the answer to that would be yes. Obviously, infection rate is something that is tracked at each facility. So it'd be hard to give a generic answer to that question. But largely speaking, ambulatory surgery centers do tend to have some of the lowest infection rates of any type of facility. Is knee replacement surgery harder to recover if you've had a partial knee replacement before? Not really, actually. I think it's an uncommon thing for an individual that has had a partial knee replacement to then have to go back and have that converted to a total knee replacement. It does happen. But in my experience, those individuals recover just as well as folks who are having a regular first-time total knee replacement. Can we talk a bit about the recovery from traditional knee replacements compared to robotic surgery? Oh, absolutely. So robotic knee replacement has been around for years, well over 10 years. It's been getting a little bit more attention over the past years, but it's actually been used for over 10 years. We've had lots of studies that have been done over the past decade. And notably, we haven't found any studies that can show improvement in patient outcomes when we use robots for the surgery as compared to not using the robots. I've used the robots in my practice. I have not really seen a difference where I can tell that this person does better than than another individual. So I think the best way to think about it is, regardless of what tools we are using during the surgical procedure, and a robot is simply a tool that we use. Regardless of the tools, the end result, we have to do a good job placing these implants either into the pelvis and the femur or into the knee in the desired position in as efficient a way as possible. And whether you use a robot or not, it doesn't change the actual steps that have to be taken to perform these surgeries. So it's not a huge surprise that the outcomes tend to be great, whether or not you use the robot. So I can't point to any significant differences, unfortunately, between those two groups. How has the procedure gotten better in the last 20 years? How has the physical therapy progressed for joint replacements? Well, to be honest, this talk really goes into a big one. We've changed our whole philosophy over the past 20 years on how to help folks recover. Many of the advancements in joint replacement, while some have been the joint replacement surgery itself, whether it's implants that last much longer. Let's look at hip replacement. If you talk to people 25 years ago, the advice at that time was a hip replacement will last 20 years. Now we tell patients this is going to probably last your entire life. So there goes a clear example of an improvement in the implants that have made them so resistant to wear that we don't expect to have to replace these in an individual's lifetime. But other advancements have come from the anesthesia side of things, being able to control a person's pain after surgery by doing the regional blocks, being able to use much less general anesthetic during a surgical procedure because the individual doesn't have as much pain because of the regional blocks, minimizing opiates afterwards so we can reduce some of the things that make a person feel bad. So lots of the reasons that joint replacement has become so successful do involve joint replacement itself, but many of those things involve all of the things that surround joint replacement: the preoperative education, the pain control, focus on minimizing blood loss during surgical procedures. Lots of tiny little details. So I would probably describe it as lots of iterations more than dramatic changes, but the totality of those iterations over the past 10 to 20 years has been massive. Will you need a pre-op MRI for hip replacement? No. In fact, that would be a rare exception if an individual did. The vast majority of the time, we make the diagnosis of osteoarthritis based off of plain x-rays, which we obtain in our office. MRI being used to diagnose hip arthritis is uncommon and really only reserved for special circumstances. So most of the time with plain x-rays that we obtain in our office, and of course a physical exam, because we really want to make sure that the symptoms that you are experiencing match up to the x-ray that we get. So if we get an x-ray, if we see an individual has arthritis, the next thing we're going to typically do is examine your hip to make sure that the symptoms that you are experiencing correspond to what we would expect based off of your x-rays. But no, you should not expect an MRI or any other type of special imaging. Everyone says the knees are much more painful and worse than a hip replacement. Is it true? I think generally speaking, knee replacements are more challenging recovery. There are exceptions every day. I will absolutely see someone in my office tomorrow who is 1 month after a knee replacement and is, walking around like they didn't have surgery. I see it every single day. But I do think that the chances of a person saying, hey, this was a tough recovery, those first 2 weeks, I had to really work hard. I think that's a more likely sentiment that you're going to hear from an individual undergoing a knee replacement than a hip replacement. Both are absolutely doable. I always tell my patients, over 1 million patients per year in the United States do this surgery. And if that many people are doing it successfully, I bet you can too. Now, you do have to come into it with the right mindset. You have to come into it ready to put the work in. And I'll be really quick to tell an individual, if you don't think that you are at a point in your life where you are prepared to put in the work to make sure you get a good outcome, then it's better to just wait and do the surgical procedure. But to answer your question, yes, I do think the most common response would be yes. I think knee replacements are a bit harder to recover from than hip replacements. My hip has started hurting because of the way that I'm walking due to my knee pain. Will my hip get better after surgery, or should I see OrthoCarolina about my knee before my hip? That's a really interesting question. So believe it or not, one of the most common reasons of a person having knee pain is actually because they have a problem in their hip above the knee. So sometimes we'll see an individual, they'll come in with pain in their right knee. We'll check x-rays, their right knee x-ray looks completely normal. We'll do an examination and we'll note that their right hip actually is very abnormal. So we'll get an x-ray of their right hip. That right hip x-ray will kind of show us where the problem is, but some individuals will feel the pain from the right hip problem, but they'll feel it in their knee. So the two are definitely related. To answer your question more specifically, anytime you have something going on in your lower extremities, whether it's your ankle, your knee, or your hip, it will make you start walking abnormally. You'll get a limp. And when you start limping, you're going to be putting stress on other parts of your body to take stress off of the part of the body that's bugging you. That can lead to pain. So I would say, yes, it's good to have both areas checked out before making any big treatment decisions. Is there a possibility of developing a drop foot after a knee replacement? There is a possibility, but we are talking incredibly rare, tiny numbers um, with a decimal and a lot of zeros in front of it. So it's something that certainly theoretically could happen, but not something that I can recall seeing in over a decade of practice and thousands of such surgeries. How does arthroscopy affect your knees before surgery? So arthroscopy or arthroscopic surgery is what many people refer to as like a knee scope. And it really depends on why you had that type of surgical procedure. Now, many people have had arthroscopic surgical procedures because they had a meniscus tear, or maybe they had an ACL tear as a teenager. And by and large, we don't really see a lot of issues when a person undergoes knee replacement at a later time in life. Now, we certainly don't see a lot of instances where folks have an arthroscopic knee surgery and then they're doing a knee replacement a few months later. That's pretty uncommon. And in a situation like that, we have to be a little bit more cautious, I would say. But for the average individual who simply has a history of arthroscopy, typically does not cause any issues. Are there weight requirements to qualify for joint replacement? There are. There are a few requirements, actually. If you are a smoker, we do have to help you with smoking cessation. It absolutely affects our outcomes, right? If you're a diabetic, we want you to have well-controlled diabetes, and the same thing. If you are overweight, that's okay as well, but there is a threshold at which point we start to see that the risk of complication, it just gets too high. And our goal, first and foremost, is not to do a surgery for you, but to help you get a successful outcome. And for that reason, yes, the threshold is something referred to as your BMI, your body mass index, and it has to be less than 40. Lots of studies have been conducted that have shown that folks with a body mass index greater than 40 that undergo hip replacement or knee replacement are at a much higher risk of complications. Now, I'll be the first to admit that that is not a perfect metric. There are many things you could say, while some people have a higher BMI naturally than others, and all those things would be valid. However, we do certainly see higher rates of complication in folks above a body mass index of 40. And for that reason, you have to be less than that to proceed with hip or knee replacement surgery. How do ambulatory surgery centers handle complications if they come up during or after surgery? That's a great question, actually. Number one, fortunately, incredibly rare, very, very rare. But all the ambulatory surgery centers do have agreements in place that if anyone was to have some type of rare issue come up, there are already agreements in place where that person can be transferred to a higher level of care to make sure they keep getting any treatment that they need. So that is something that is worked out ahead of time, and fortunately, it's something that is not needed to be used very often. Well, excellent. I'd like to thank you all for attending tonight's webinar. Please keep in mind that this recording is going to be posted on all of our social media channels, so feel free to check it out. If you have additional questions after tonight, feel free to share it with your friends or loved ones who may be considering treatment for hip and knee arthritis. So thank you for attending, and with that, have a great evening.